1st. Today is World AIDS Day, and the logo for World AIDS Day this year is Ending the HIV Epidemic, Equitable Access, Everyone's Voice. Today we have an esteemed panelist that is here to share with you their expert and research areas on HIV/AIDS. And I want to again welcome you and glad you're joining us. I know it's a busy time of the semester, also the year with the holidays. Today our moderator is Sharon Wilkes, one of our fabulous instructors, and she's the one who really spearheaded the whole Noontime Knowledge series. So we're really grateful for her ambition and sharing with everyone her talents. So Sharon, I'll turn it over to you. Thank you.
Thank you, Peggy, for that warm introduction. Good afternoon, everyone. We're so excited to host this panel presentation today. And as Peggy stated, today is World AIDS Day. And so we have 3 esteemed panelists. You will be very just appreciative for what they have to share with us today. So our first panelist is Dr. Scott Beatty. He is an associate professor in the Department of Social Work, College of Arts and Sciences at the University of Alabama at Birmingham, with secondary appointments in the Division of Infectious Disease and Department of Health and Health Behavior. Dr. Scott is a scientist with the UAB Center for AIDS Research, CFAR, where he leads the center's community engagement efforts and the engagement and continuum of care specialists. Dr. Beatty's research focused on eliminating health disparities, especially those prominent along the HIV continuum of care. Within this framework, he conducts mixed methods research to answer important research questions. Informed by 23 years of experience as a licensed social work clinician, his implementation research especially leverages the inherent skills of social workers to uniquely deliver evidence-based intervention. It is routinely community-placed and community-driven. Dr. Beatty's major scientific contributions centers on implementation of promising interventions and delivery strategies that effectively and efficiently addresses gaps in the HIV continuum care. Utilize evidence-based social work practice, reduce health-related stigmas, and optimize the primary medical clinic community interface. Dr. Beatty lives with his husband of 26 years, Brian, and there are 3 French bulldogs, Nola, Napoleon, and Ollie Merle. And Dr. Scott, if I mispronounce your baby's names, please correct me.
You're perfect, Sharon. Very happy to be here. Thank you.
Thank you, Dr. Beatty. We're glad to have you today. Our next panelist is Dr. Pamela Payne Foster. Dr. Foster is a preventive medicine public health physician who currently serves as a professor in the community medicine population health department at the University of Alabama School of Medicine here in Tuscaloosa, as well as deputy director of outreach for the Institute for Rural Health Research. Dr. Foster's current research area of interest is the study of HIV/AIDS related stigma in rural African Americans in Alabama, particularly in the faith-based setting in rural Alabama. Dr. Foster received her BS degree in chemistry pre-medicine from Xavier University in Louisiana, and her MS in biomedical sciences and her MD from Harriet Medical College in Nashville, Tennessee. Dr. Foster completed an internship in internal medicine and residency in preventative medicine public health at State University of New York at Stony Brook, where she also completed her MPH at Columbia University. Dr. Foster has served on the faculty of a variety of institutions, including Morehouse School of Medicine, George Washington University, SUNY Stony Brook, and the National Bioethics Center for Healthcare and Research at Tuskegee University. Dr. Pamela Foster, thank you for joining us today.
Thank you also for having me, Ron.
Thank you. And our final panelist is none other than our own Dr. Karen Johnson. Dr. Johnson is an assistant professor of the University of Alabama School of Social Work. She received her PhD from Columbia University School of Social Work and her MSW from Silberman School of Social Work at Hunter College. Dr. Johnson completed postdoctoral training in global mental health and implementation science from CU, New York State Psychiatric Institute. Dr. Johnson is an affiliate with the University of Alabama at Birmingham Center for AIDS Research and a UAB National Institute of Health funded by Minority Health and Health Disparities Research Fellow. Dr. Johnson's research is macro in focus. She explores historical, cultural, and contextual factors such as trauma, oppression, religiosity, stigma, and place that derive sexual risk behaviors in Black women in the criminal justice system in Northeast and the Deep South. Again, welcome, welcome, welcome. We're so excited to have you today, and we know that we're going to learn a lot from you. And again, as Peggy stated, today is World AIDS Day, and the theme for today is ending the HIV epidemic, equitable access, and everyone's voice. So we will get started with this rich discussion. And I'm sure Ms. Peggy stated, if you have any questions, anything that you would like to share, please use the chat to ask your questions or any comments you may have. And so World AIDS Day was first observed in 1988. That's been a lot of years. And so I have a question to the panelists. What are some ways which HIV have improved since the first World AIDS Day happened? And what are some ways we need to improve, particularly in the South, as Dr. Johnson said, in the Deep South? And if I need to repeat that question, I will do it. And so that's to either one of the panelists, either one can respond.
I'm unmuted first, so I'll get started. I just want to first say I am delighted to be on this panel with colleagues. We work together closely. I forgot to say, Sharon, that I'm also affiliated with the CFAR, Center for AIDS Research at UAB. So have known Scott for a while, and he is he has that collaborative spirit, which I think is a social work attribute. Yes. For sure. I'm married to a social worker, so I can say that. And Karen is also a mentee of mine here. So we have definitely collaborated. I saw an article today from Dr. Fauci talking about COVID and HIV. And so we all know COVID has just disrupted our lives over the last 2 years. And what he said in the article is that we have resources got diverted from HIV to COVID. I know as myself as an HIV researcher, I have been doing COVID work over the last 2 years. So even the human resources and the money, more particularly the money. And he said we need to get back to putting those resources back in. I have seen, though, over the decades since World AIDS Day, when we had the whole concept of prevention as treatment, that we have made a lot of strides around that whole area, really trying to get people tested, trying to get people staying on their meds, to get them to a zero viral load, a low viral load, so we don't transmit the disease. So the whole idea of eliminating HIV really is in our sights. But at the same time, I still would like to see much more of a focus on Black communities, Black men and women. So we know the low-hanging fruit is men having sex with men, but I don't want women to be forgotten about. And the part about everyone's voice comes to mind because I think, and Scott probably and Karen would say, we probably need to be moving more towards a community-based approach rather than a biomedical approach. So the prevention treatment is a biomedical approach, which physicians and scientists are very comfortable with. But you as social workers, many in the audience, social workers, we have to have that community-based approach or we will never get to that 2030 elimination of HIV. And I'll stop there. my colleagues to add in.
I can go second. Thank you. I know Scott was allowing me to go second. I appreciate that. Yes, Dr. Pam is a mentor of mine, and it's such a pleasure, Dr. Pam, being on this panel with you. And thank you so much, Ms. Wilkes, for inviting me to this conversation. As I was listening to your question, I was thinking about the face, right? The face of HIV. The story has, since the first World AIDS Day, the story has changed significantly. So there's so much to be proud of as a nation and as communities within communities, because there are significant accomplishments made in terms of biomedical approaches. We now have a pill. Many people don't know about this pill though, but we now have a pill that you can take, and actually several that you can take to help prevent HIV. However, areas, particularly in the Deep South, in terms of your question, areas of the Deep South, it is still quite a secret that this pill exists. My research is community engaged as well. And so I talk with women who are justice involved. So these are women who have all been arrested, have all been convicted of a crime, and they are either completing their sentences while living in the community, or incarcerating in forensic setting. And the ones who are living in the community, there's a lot of lack of information, right? And so for those of you who might have been to other talks like this, you hear that, the population is hard to reach. And I really like to turn that on its head and say that we just continue to struggle in our efforts to reach them. There's nothing wrong with the population, right? Whether you're talking about with women who are in the legal system, the criminal legal system, or you're talking about other populations who are impacted by HIV to the rate of back when it was first discovered. So if you kind of think back, this will be my last comment. If you think back a couple years ago when we first heard the term COVID, right? We didn't know what was happening, and so many people were becoming, it was being transmitted to, right? And now 2 years later, that number has decreased steadily, even though it's still far too high. Yes, we've seen steady growth over the 40 years in terms of HIV, but like a statistic I shared yesterday in another talk was women between the ages of 24 to 35, in that age group alone, for every 10 women who are become newly transmitted, 9 of them are Black. That number is shocking 40 years later. And the numbers in the Deep South are, it's the epicenter of the HIV epidemic. So there's a lot more work to be done. Thank you.
So I have to echo my colleagues' comments. I could not have more respect for the 3 of them that are on this panel with me, and the moderator as well. So it's a pleasure. And it's not surprising either that I don't have much to add after hearing from both of them. I think World AIDS Day has always been, well, maybe not always, but certainly now, is both a time to celebrate the things that we have achieved, but to really be introspective about how far we have left to go. And so I appreciate this question, because when Sharon referenced the first World AIDS Day, and I pictured myself there, and what a very different world it was then. And so in addition to the single pill preventative that Dr. Johnson spoke about in terms of PrEP, we also have much more tolerant, durable antiretroviral therapy for people living with HIV. In fact, we have prevention campaigns that people who are living with HIV and can take their medication as prescribed and are adherent to their medication and their appointments can become undetectable. The term that we use, undetectable, meaning that their viral load biological marker falls below a detectable range or number. And this means that these individuals are incapable of transmitting the HIV virus to another person. And this is remarkable science. I actually teach an elective course in our MSW program from a textbook, because I don't have many to choose from, but from a textbook that says, that's about 10 years old, and says that we will never be able to say beyond a shadow of a doubt that something cannot happen. But in fact, in 2018, 2019, the CDC did come out and officially say if a person is undetectable and are adherent to their medication regimens, then they cannot transmit the virus. And this not only has implications at the individual level, so people who take their medications and remain engaged in care, we know that they have better HIV health outcomes individually. For example, near normal life expectancy. So a person who is healthy and yet living with HIV may live as long as I would for a number of reasons. But it also has important public health implications as well, because I think that that's a major way to protect the public health, is to keep people who are living with HIV virally suppressed. So I think that those are some of the things that we can celebrate, but I would be remiss not to echo the very serious concerns of my colleagues that health disparities exist, and they're very prevalent still in HIV, both along the lines of race, ethnicity, geographic region. All of those are very important markers to be aware of. And to think about how far we've come in a short amount of time and how disruptive a global pandemic might be for the reasons that Dr. Foster spoke about. My concern now is how do we keep the momentum in HIV going in the midst of this global pandemic when, if nothing else has happened, so many of us have been pulled into the COVID world.
Sharon, I just wanted to just echo burrow down on two key points that Sharon and Scott made. First, although we've made these strides, the evidence is there. The community does not know about it, particularly the Black community. If we look at the disparities that Scott mentioned, there are 7 out of 10, that Karen mentioned, 7 out of 10, I think 7 to 8 out of 10 new cases of HIV in Alabama will be Blacks, that education Karen talks about with her population of imprisoned women. I did a study with Amy Nunn where we looked at the Deep South. So not just in Alabama, but Mississippi and Arkansas. We interviewed 65 pastors, African-American pastors. None of the 65 knew what PrEP was, which is pre-exposure prophylaxis, exposure prophylaxis for HIV. So that's a pill to prevent HIV in someone who is negative. And no one knew what U equals U is, what Scott talked about, undetectable equals untransmittable. And these are campaigns, public health campaigns, but we have to do a better job of getting those messages to people so that we really can use the evidence base. The translation of the science has to go further out into the community. And that's where we're going to probably have to spend much more of our time taking what we know works, and which is what is good public health practice, and translating that to the community so they will know. And I think it's going to take also this part about everybody's voice, everyone's voice. It's going to take community leaders. I see Reverend Spencer, he was a part of this study, Chris Spencer from the Black Belt Community Foundation. Pastors, community leaders, mayors, legislators. We have to have a larger voice around these issues I can tell you from my own experience moving from New York and living in DC and Atlanta, where the advocacy voice around HIV is loud and strong, it is almost somewhat silent and muted in the Deep South, particularly in the rural Deep South. So we have to have much more of a louder voice. That's not just going to be from people living with HIV. Of course, they should be leading that charge, but it's going to also take community leaders, our communities also understanding what these issues are and participating in the change that we need to see in the community.
Yeah, may I also say I completely agree, and we haven't, while we've made tremendous accomplishments, we haven't ever fully, and I'd be hard pressed to quantify it, but we haven't yet ever fully moved away from the stigma attached to it, right? If you think the parallels between COVID and HIV are, we can make
They are striking
all day long, right? But if you think of it, remember within the COVID kind of trajectory, which is quite new still, but when it became clear that with the exception of some pathways of transmission that continue to cause many to scratch their head, right? But certain groups were more likely, groups of color, people who were overweight, people with certain pre-existing conditions, many of which might be tied to health practices, like poorer health practices, and the attention of the community at large seemed to shift, right? There was less kind of empathy. And it was more kind of like a stigma attached to it. If you weren't chubby, if you weren't fat, if you weren't, you know what I mean? Like, it's your fault, right? So HIV times a million in terms of stigma, right? Because the pathways are still groups that are undeserving, right? Men who have sex with men, right? Women in the justice system, people who are using drugs. What? You know what I mean? Like, you guys are, and I think that's why 40 years later, we continue to struggle with one voice, right? And I think that's one of the things that we haven't yet dealt with. Yesterday in the talk, I shared a quote from someone I interviewed, and they used the word rural stigma, right? And there are geographical differences, right? As Dr. Beatty was saying, that impact the will to come together around this, right? And yes, we've seen growth, faith-based communities who've stepped up, for every one faith-based leader who stepped up. I'm not sure what the number is, Pam would be better able to say. There are quite a few others who may be a little less comfortable because of the stigma attached to how one acquires this.
And that's still, Karen, that's still a major struggle in the South. There have been some campaigns. I think SAC funded a campaign to put billboards of people saying they were HIV positive in Montgomery, which is a major step. I think they got about 18, 20 persons to do that. But still, it's a struggle. I had a radio show the other day, and we were hoping that the person who worked for an AIDS service organization would say she was positive, but she didn't say even in that interview. So, and this was a female. So I think it's still very much a struggle, more so in the Deep South where the religious values are so strong. But I was going to add, Karen, that it was funny. I was at an event maybe close to when the shutdown happened. And there was a person with HIV, living long with HIV, a long time with HIV, who said this pandemic it brought back flashbacks for them, that the stigma, that the things they were hearing were the things that people said about him when he was, diagnosed with HIV. And it was almost like this flashback of hearing some of the stigma. And I think you're absolutely right. And we have seen more of a push to really deal with the underlying stigma, because unless we do that, we're not going to really get far. over the years, I've seen more of it, more of a push for it. And we work, Scott and I work a little bit more directly in the stigma realm. He works in the healthcare stigma realm. I work more in the community stigma realm. And one of the reasons I did that was when I moved here from New York and came to Alabama, I saw that it was just totally quiet around World AIDS Day, for example. And when we interviewed myself and Susan Gaskins, a professor who's retired now in nursing, we interviewed people living with HIV in rural Alabama. We asked them where they felt most stigmatized, and they said the church. So we said we really have to really work with faith leaders around stigmatizing HIV persons, and really, and surprisingly, the other finding we found was that those, even though they were stigmatized by the church, they felt spirituality was very important for them in living successfully with HIV. So trying to bring those communities together has also been another goal of mine in particular. And we're seeing more and more of that slowly happen.
Yes, I too agree with everything that y'all have said. It's such a stigma and it's a taboo, especially in the Black community and particularly in the Deep South. And so I relocated to Alabama, and my first job was with HIV at AIDS Alabama, and that's how I became to know Scott and have grown to love the work around HIV. And it still continues to be the silence. And so I continue wherever I go, whatever path I'm on, I still keep HIV at the forefront because it's a very important topic that we must continue to talk and have these conversations. And Karen, just to echo what you said earlier, you talked about that population that's kind of hard to reach, particularly in the Black community. And though we have made much strive and great contributions since the first World AIDS Day, what seems to be those indicators, or what are those barriers to keep us from having these conversations and getting into the communities? And as Dr. Foster said, it's going to take some grassroots efforts. It's going to take boots on the ground to get in communities and to educate people. Because if people are not aware of the statistics and whether the medication works or not, how would they really trust and even understand the systems and the things that has already taken place?
And I think she booted that to you.
Oh, you know what? I was going to wait for Dr. Beatty because I feel like we. Dr. Beatty, I'll go after you or after Dr. Pam.
Well, I think that again, the issue around stigma cannot be understated. When I think about what has to change, I mean, if I'm honest with myself, what has to change is the reduction of this stigma. First and foremost, more than anything else, I think that's what has to change. Now, unfortunately, if the next question is, well, how do you change that? I don't think we know the answer to that quite as much. When I listen to Dr. Foster talking about the stigma that exists for people living with HIV in the community, I'm also thinking, okay, well, that stigma also exists perhaps if I'm African American, perhaps if I'm gay, perhaps if I'm Christian, perhaps if I live in the rural area. And so there's this there are these intersectional stigmas that we have to deal with, number one. And then the other thing that Dr. Foster reminded me of is that if I'm stigmatized as a person living with HIV in the community, but through the work that she and I have done together, we know that stigma also exists in the healthcare setting, in the HIV treatment healthcare setting. Then what does that mean for me as I'm seeking care, as I'm learning to take my medications, if I can't go and feel comfortable in my healthcare setting? This is a powerful thing. Another issue with prevention, regardless of the other intersectional stigmas, is that there's stigma around PrEP use or pre-exposure prophylaxis. And I've talked to individuals and had interviews, much like Dr. Johnson has, around this. And people say, I don't want people to see me taking a pill, even if it's for prevention reasons. So they may see that pill and recognize that it's an antiretroviral therapy and automatically think that I'm living with HIV. So that's another stigma. Or they may know that I'm taking a pre-exposure prophylaxis and think that I'm promiscuous and that I'm, that I'm out. And so there's that stigma. And so how do we mobilize a community around this? And the last thing that I'll mention in terms of stigma is that I would also say that stigma is a factor in terms of being able to tap into people's voices and for people to become an advocate. Because I know when I first started doing this work, and I don't think that this has changed. There's actually been quite a bit that has changed in 25 years. But when I first started doing this work, I remember thinking very seriously about what do people think of me going and doing. I just have to mention this. I saw Madeline Hill on this call, who was actually one of my master's level instructors.
The great Madeline Hill.
The great Madeline Hill, who I remember and fondly, and so thank you for all of that, but was very active in HIV work in the Tuscaloosa area. And I can remember when I was doing a field placement at what was then West Alabama AIDS Outreach, but has now grown infinitely under the leadership of Dr. Kirkpatrick, walking into the building at WAYO thinking, are people going to think I'm positive? Are people going to think I'm gay? Are people going to think I'm a drug user? And that followed me, not just as an MSW student in Tuscaloosa doing this work, but even making this my career. Like, how do I tell my family and my loved ones that this is such a significant public health concern, that there can be passion around this without taking on or perpetuating all of these stigmas that exist around it. So it's so complex. We could
I just
actually
want to
talk
follow
weeks
up,
about stigma.
Sharon, I'm sorry.
No, go ahead.
You said it best. I think you said boots on the ground. And so I was thinking about, we definitely need training, we definitely need education, but we need to partner with community organizations to do this work. And it can't just be the AIDS service organizations. Their stretch is not wide enough to get to the Black communities. We need some other Black organizations. We need monies for cities to take on this work. We need, and so in other words, the boots on the ground has to have some money attached to it. First of all, the recognition that the boots on the ground is important and that there's money attached to it to do the work. And I think there are many organizations, that was true from the study we did. I was talking about Faith in Action with the 65 pastors. They said they were willing to be those groups that did the work, but there has to be training attached to it. They have to understand about HIV, about U equals U, about PrEP. And they also were willing to partner with scientists, with clinics, with AIDS service organizations, but as a willing partner to do the grounds, boots on the ground work. And I think that's where we're missing. We certainly missed that with COVID. We could have been doing a lot better with COVID if we had those connections with those community organizations to do boots on the ground work. And so I think that's really a part of what that equitable access and everybody's voice is pushing for, if we're really going to take this, end this epidemic by 2030.
Oh, I'm sorry. Do I have time?
Dr. Johnson.
Yeah, okay. I was thinking of the term cultural humility as you were asking the question, because I feel like, so cultural humility, it's pretty kind of self-explanatory, right? It's a term that's used in kind of community engagement space, speaking to the fact that as researchers and providers, we need to be wholly humble in terms of how we engage. The term community engaged research and different kind of synonyms to that term, they've been around for decades as well, right? And while we know some things, as Dr. Beatty was saying, we don't know enough. And I think part of it sits in that term. The level of humility that we have as researchers is perhaps a drop in the bucket to what it needs to be, right? And I know I've done this myself, and partly because of the pressures, trying to get funding and trying to get the work out, right? But we don't do it well. Some of us do it pretty well, some of us do it pretty darn well, and some of us kind of fell at it miserably, right? And part of what happens is we stomp on the feet of the community. And the community has to be out front. One other thing I'll say real quick.
Hit me in the gut when you said stump on the feet of the community.
Yeah.
So true. So true.
Yeah. There's this model that was introduced by a gentleman who went to Columbia University. I don't know him well, but I so respect the vision, because what he did was he took a model and he turned it around and kind of turned it on its head. And I think that's going to be required if we're going to have some success in this space. It's called Housing First model. And basically what he said was, his name is Dr. Sam Simbaris. And he basically, what was happening before then in the space of homeless activism and getting people into housing was people had to jump through all these hoops before they could qualify for housing. And he said, what are we doing here? These are people who are on the street or at risk of going on the street. I think his work was really on people who are actually on the street. Get them into the housing first. Once we get them into the housing first, then we'll do all the other stuff, get the paperwork, because we would lose people and they're at risk while we're trying to get their social security card or, processes that are necessary. So I guess what I would advocate, and I think it will make a tremendous difference, is community first. You know what I mean? Like, we go in and we're leading the community to the table. The community has a lot of knowledge. We need to learn from them. And how do we do that in a way that brings the money in that might be useful for the community? I'm not quite sure, honestly, but cultural humility is—
That takes some finagling and partnerships where the community has enough trust to know that we're not leading them, we're working with them. But really, so there are enough community organizations that have enough finesse to go after the money themselves and come to us for support for whatever they need. But we probably need to be working on those and building up the capacity of others to do the work. Simple, pretty simple, but difficult, but simple.
Yeah, I think that you guys are spot on. And Dr. Johnson, I had actually written down that one of the things that we need to do, I didn't say it as eloquently as you did, but I think that what we need to do as people who, because of our privilege, are able to sit around the table, that we need to stop and be introspective. I cannot tell you the number of times that I have sat in a meeting with a boardroom full of mostly white men and a few white women talking about how to engage the community and what we're going to do about HIV. And feeling like, oh my God, I hope there's not a camera in here and seeing me participate in this mess, because this is laughable. And so I appreciate what you've said. And then Dr. Foster, to your point, I think, with 30 folks or so on this call today, that if you can be motivated from hearing where we stand now and how far we have to go with HIV, and recognizing that with the low-hanging fruit, I love that term, Dr. Foster, that if we can just kind of pick that and leverage that, and each of you take ownership of having this public health impact, have a conversation. Don't be afraid to have a conversation with your family, with your friends, with your church members, with your social network. The power of 30 people and the representation that I see just on this call can, it's not going to change the world. It's not going to change the HIV epidemic in the United States, but can it make an impact in Alabama, in West Alabama, in Birmingham? Well, that's a start, and I would accept that as tremendous progress. So,
And actually, from that the pastor study, we have to understand some of the micro pandemics or micro epidemics that are going on. Certain zip codes, we know certain zip codes, we know certain counties have higher rates than others, and really begin to kind of key in on those particular areas. I like what you said, Scott. We may not change the world, but we certainly should change where we live. And Alabama should be at the beginning of that, as working here at the University of Alabama. Our emphasis should be on Alabama and where, the communities where we live. So I think I love what you said about all of us playing a role in that and having some part of that key to get us to ending this epidemic by 2030 is how many years away? 9. We've got 9 years to get to work, y'all.
Yeah, this has been a rich conversation. And so, we know in universities, of course, we have research focus, and we have to be able to build the trust in the community and not just go into community because we're doing a research study. And oftentimes, because we have these research studies, there's no sustainability plan. And then people are left right there. And so how do we sustain the work long after the dollars have gone?
Yeah, I love that, Sharon. It really boils down to relationships.
Yes.
I mean, I even after the money is gone, I still have numbers in my phone. I tell you one thing that was interesting, because relationships do matter. They're very important for building that that trust with community organizations. I had pulled together 5 organizations that I had been working with in the Black Belt, calling it a Black Belt collective. Black Belt Community Foundation is one of them, Sowing Seeds of Hope down in Marion, Alabama. I don't know if many of you know Francis Ford. Black Belt Roots, Rashonda Workman, Alabama Prevention Center with Loretta Wilson, and I'm missing, in Hale County and now in Perry County, Horseshoe Farms. All of those organizations doing different things around the broader issue of health. And I was really pulling them together for them to begin to work together around issues, health issues, not just individually, because each of them has their strengths, and together, I think that would be better for going after larger grant funding. We went after a large Robert Wood Johnson, Chris, was it a Kellogg Foundation grant, 20 million, 10 years. We were a semifinalist, but we didn't make the final cut, but that's where I was trying to get us to, so we could really talk about broadband expansion, right? Internet expansion. Don't think of it as maybe an HIV issue, but if you're going to do telehealth with HIV patients, it has to be part of the equation. One of the things I found out was that when COVID hit, they called and said, can you do a talk? Or we need some masks, or we need this, what I can do for you. So it's sort of a reciprocal relationship that just kind of escalated during COVID because of COVID, because it was an emergency. So I think thinking about developing those relationship long terms, many of those groups that I mentioned, those 5 organizations, I've never written a grant with. I've been at the university 15 years. So you're talking about 10-year, 5-10-year relationships. And Karen is right. The pressure is on to do grants but you've got to build the relationship first. And so really at the same time, maybe giving them what they want, because sometimes it may not be HIV, it might be something else. And then me saying, okay, what about HIV? Maybe we can do this way. So it's a negotiation, but you can't negotiate it when you're not in a relationship. And the negotiation is also understanding that they bring value to the table, as well as what I bring as a researcher. So
that's good. So we have about maybe another 5 to 8 minutes before we wrap it up and turn it over to Peggy. We have a question from the chat, and we know this is a real barrier. What is the cost of medication that will prevent HIV/AIDS? And does the insurance cover the cost of medication? And we know for people who are living in poverty, the cost of medication is very astronomical, and that's a barrier. So that question can be answered by any panelist.
Yes, Scott, you got that one?
Yeah, sure. I'll jump in. So in terms of the medication that'll prevent HIV/AIDS, just once again, we call it pre-exposure prophylaxis, or PrEP. It is basically 2 antiretroviral medications. One is Truvada, 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 I think, and the other is Descovy, Descovy. And there are the research pipeline. There are some other strategies that are currently in place that we might see approved in very short order, like injectable PrEP that does not need to be taken, does not have to be taken daily, but instead is taken. Dr. Foster, you may can help me. It's either monthly or every couple of weeks, but anyway, less frequent.
Yeah, maybe every 3 months.
Yeah.
Yeah.
And so the science around that prevention is there. The uptake, especially among those populations with the most health disparities, is not there. Just one other bit of number that I'll share with you. I collaborate pretty closely with Birmingham AIDS Outreach, and through their Magic City Wellness Clinic, they provide PrEP to anyone. They are the largest.
Free?
I'm getting there. They provide PrEP to anyone. They're the largest PrEP provider in the state of Alabama. They have over 300 individuals on PrEP. I looked at their numbers this week, and 3% of the people that they have on PrEP are African American. Everybody else is white. Everybody else is male. So now to the cost. So the cost is, this is Beatty's word, astronomical. I don't know that I could afford it in some cases, but rare cases. Insurance is available for it, but that is rare. And most of the time, what has to happen is that agencies are relying on for lack of better terminology,
grants,
care and grants, or through the pharmaceutical company to cover the cost of those medications. So it is, as Sharon said, a tremendous barrier. And how do you get people that are not adequately resourced or who don't have access to care on something like this if you make it so difficult for them to reach? It seems so simple to us to get access to a pill every day, but even if you can get yourself to the place that can provide you with PrEP, the cost and the financial barriers are significant. However, I would always say that if you are not aware of the ins and outs of the availability of PrEP, always encourage, you yourself, or encourage people that you know to ask the questions, because some of these agencies do have some workarounds with being able to provide PrEP to even those individuals that do not have insurance, like I said, and it's unique from place to place. And I know that Karen or Pam can probably jump in on that.
I wanted to mention a couple of, thank you, Dr. Beatty. I want to mention a couple of other organizations. Dr. Scott mentioned West Alabama earlier. I think you mentioned Five Horizons, right? Did you mention that name? So Five Horizons is located in Tuscaloosa, and they're wonderful. Dr. Billy Kirkpatrick. Say Fitzpatrick. I'm like, that's wrong. Dr. Billy Kirkpatrick is, and I'll drop the link in the chat in a moment. And in Selma Air is another fine organization. These organizations, they're called AIDS Services Organizations, ASO. So if you're looking for one that's in your community, if you're not close to any of the 3 that you've heard mentioned, Dr.
Yeah, those 2 have PrEP clinics, correct?
Yes.
And maybe Watley has the federally funded clinic here has an HIV clinic. not sure if they have a PrEP clinic, but they also have HIV services as well.
Yeah.
Yeah,
We'll
but
put
that is
that-
a huge, what Scott talked about is a huge barrier, the cost.
Yeah.
But in addition to that, I mean, one of the other reasons for the uptake is mainly in white males. It never was advertised for Blacks. I mean, the advertising was sort of white male, so that was a fault from the beginning. Women were left out of the equation, as well as Black men. And the outreach to do outreach for really educating the community and getting them to understand the value of PrEP was not there. So we're kind of chasing behind that as well. All those things, the evidence base, again, Scott, the biomedical model is there, but really thinking about how it gets outreached to the communities that really need it is our uphill battles in addition to the financial.
I wanted to kind of go back to something Dr. Beatty said earlier, and he used the term intersectionality, which we know quite well as social workers. And it's, this is such an awful turn of a phrase that I'm going to use, but it comes to mind. It's like death by 1,000 cuts. And among the marginalized groups that Dr. Beatty mentioned earlier, he talked about race as it intersects with sexual practices, as it intersects with like legal system status. Poverty is huge, right? And access to care, equitable access to care. The statistic in Alabama alone, in the last, 20 years? No, 10 years, there are like 20 hospitals and clinics that have closed. In a state that needed more, not less. And so getting access, whether it's in terms of how much money you have to pay for it, do you have insurance or not, but also just transportation access. Dr. Pam talked about broadband, so it's like death by 1,000 cuts. It's not just HIV, right? And it's not just a stigma related to HIV, it's poverty, and it's kind of chasing the funding in order to get the needs of the community met. We put in a whole bunch of links in the chat to these different providers just for people to look at.
You gotta love those social workers.
Very resourceful.
There's a link from the CDC that talks about how do you pay for it for PrEP. So some resources there for you, okay?
Thank you so much, which brings us to a close. And so I have one question, and so we'll wrap it up, and I will turn it over to Peggy to close us out. So what are some potential strategies to improve the health outcome of HIV among the population who are experiencing these disparities around HIV? And particularly, what can we do to better educate our students, specifically social work students? What can we do to further educate and spread and increase the awareness? And not just on December 1st, but how do we continue the conversation? And I think that's where, I wouldn't call it an issue, but we wait for these observation days and we're AIDS Day. And so that's what brings us here today to have this conversation, but how do we continue the conversation?
So if you don't mind, I'll jump in on that. I have some strong feelings. So I really think that social workers are uniquely positioned to put a dent in this epidemic because of all the things that we've talked about. Traditionally, they volley back and forth from the clinic setting into the community. They know the landscape in the clinic and in the community. And so I think social workers are vital. Probably in the days when I was in my MSW and a little bit rogue and didn't know what I was doing, and Dr. Madeline Hill was trying to rope me in, I probably didn't give the time to listening to the messages that I should have about evidence-based practice. And while evidence-based practice in and of itself does not address some of these larger structural issues that we've talked about today, like stigma and health disparities, I do think that the implementation of evidence-based strategies that are specifically targeted to particular populations can be impactful. And oftentimes in the work that I do in randomized controlled trials, it's social workers delivering those evidence-based interventions. So currently we are leveraging social networks for young African-American men who have sex with men who are living with newly diagnosed with HIV to help to have a support confidant to help them through their HIV journey and ultimately become virally suppressed. Dr. Foster and I have worked with what I would call less micro level, maybe more meso or macro level interventions around HIV stigma reduction within the healthcare setting. I think that I could go on and on and on and on. I think that these interventions show promise, and we need funding to continue this work. But we also need the cultural humility or the introspection that has been mentioned before, that when we're delivering these things, that we are cognizant that we're not, sitting from within the high house of academia and just delivering, coming as the savior to the community to save them from themselves and everything else. That's not the way to do that. But we really need to think about the science of implementation and the evaluation in the real world of these evidence-based practices. And there's nobody that's better equipped to do this than social workers. So let's do it, guys. Do it.
Thank you, Dr. Beatty. So we have come to the hour.
Can I just add one
yes,
piece?
ma'am. Yes, please.
I really want to push the activism piece, because I think this is a season of speaking up and speaking out. We know with the Black Lives Matter, I was so proud of the medical students that did a die-in, but they said, where are our professors? Really not comfortable in those spaces of activism. I'm really challenging. I know social workers have been in that space much more than physicians, but I'm challenging us to speak out a little bit more. Op-ed pieces, right? About some of those issues. We need more money. I just put a piece on my Facebook page of a group organization I work with, really advocating for more monies to go into the communities around these issues. So activism would be and speaking out would be because really ACT UP, if we go back to the 80s when HIV first started, ACT UP really was the ones who transformed HIV, and we need some more acting up.
Here. I don't.
And I agree. Yes, because that's as social workers, we promote social justice.
Yes,
and we have to give back to our foundation.
Yes.
To become more activists and then to teach it. So how do we teach our students to become activists?
We have to role model it.
Right. So the time has come. Dr. Johnson, do you have a closing remark before I turn it over to Peggy?
Thank you for that. I would say intersectionality. Dr. Beatty used the term, and I think that's really important. When we see the interconnectedness of issues, I think that's one of the ways we teach it and we model it. HIV is not a single issue matter. It touches so many things, and like the parallels between COVID and HIV and broadband and transportation, like they're all related. And when we train ourselves and our students to think about the macro, yes, meso and micro, but like the macro interconnectedness of it all, I think we are more effective in advocating and intervening.
Yes. activism.
Thank you for bringing it on home, man.
Yes.
On home,
Culture
Dr. Johnson.
humility, because we have to get out of the way of ourselves and not be here, but boots on the ground, working with everyday people, and and let them know that your life matters. Regardless of what the situation may be, we are here to work alongside of you. So with that, I will pass it on to Peggy to close us out. Again, Dr. Foster, Dr. Beatty, Dr. Johnson, thank you so much for always answering the call. I appreciate you. The School of Social Work appreciates you. And so for that, we thank you and have an awesome day. And I'll turn it over to Peggy as well. Oh, Peggy.
That's okay. Thank you. Thank you again, everybody, for joining us. Thank you, panelists, for sharing resources. I'm capturing all of those, and I'm going to send out the resources to everyone who's participated in today's program, along with your CEU certificate. So, and then I noticed Dr. Beatty put his contact information. If the panelists are all okay, I can put their emails in there as well if you have other questions.
Yes, that would be great.
Thank you. Thank you. And I know there's toolkits out there as well. I'll share, on ways to help support, communicate, collaborate with partners, how to share on social media, using the hashtag the World AIDS Day, but it is every day.